All right, so we're going to try to finish up the rest of the structures for the eye, as well as a little bit of some of the conditions that we see in the eye as well. So inside of the eye, there's actually some fluid. There's two basic fluids. There's what's called aqueous humor and vitreous humor. We're going to talk about those here in just a second. Aqueous humor is kind of this watery-like fluid, similar to almost like saline solution if you wear contacts, or essentially just kind of thicker water that actually sits between in the chamber between the lens and the cornea. It's got a couple different features that it provides. So it's really similar to blood plasma in that it helps maintain kind of the ocular pressure, the intraocular pressure. So it allows the cornea to keep its kind of rounded shape out in front of the eye. It also does provide some nutrients to both the cornea and lens. And then when it's time to kind of get reabsorbed and add new fluid back into it, it gets reabsorbed through these little things called the canal of Slem, which are these little small canals kind of down towards the bottom of that anterior chamber. The vitreous humor, on the other hand, is more gel-like. I always remember, at least for me, aqua. Aqua means water. Vitreous, the V to me always means like viscous or thick. So I always remember this one is more gel-like. And this one actually sits behind the lens. And its purpose essentially is to keep the eye from collapsing. So it allows kind of the rest of the eye to keep its shape. Unlike the aqueous humor, the vitreous humor does not get replaced. It pretty much is there from the minute the eye forms until death. And that can create a couple of problems. People can actually develop what are called floaters inside of this vitreous humor. So as parts of the vitreous humor start to kind of harden or kind of calcify a little bit, they get these little pieces that look like hairs, or in some cases, people think they look like animals kind of floating in the back part of the eye. But essentially, they're just portions of that vitreous humor that have kind of calcified a little bit, and then they'll have that little bit of a piece in their eye pretty much the entire time. In between those two then is the lens itself, right? So the lens is what we refer to as a biconcave. So it's actually concave on both sides, right? Kind of draw you a little bit of an image of that. So it looks similar to this on both sides. And then because that's how it helps kind of form some of that light towards the back of the eye. It is held in place by those suspensory ligaments that are attached then to those ciliary bodies. And the purpose of that is essentially to change the shape of this lens to help us refocus that light right here on the back portion of that fovea centralis. As we get older, that lens hardens and doesn't change shape as well. Most eye doctors will tell you that around the age of 40, is when we see kind of changes in that process. So there are people usually who are essentially nearsighted, means they can kind of see things up close real well, but things away, lose that ability to kind of change focus. So they can't look at something close and then look away. Their eye takes quite a bit of time for them to kind of focus on that. And it's because of that changing of the shape of that lens. The lens has to be able to do a couple different things. So you can see it by changing shape. What I mean, it has to kind of change its profile, and we refer to this as lens accommodation. This is where the light actually is being focused on the back portion of the retina at that focal point. So what we normally say is that the eye is set to see distances at over 20 feet. So anything at 20 feet is kind of a normal. That's why we always refer to things as whatever out of 20. So when you go to the eye doctor, the eye chart is 20 feet away from you because we want to know what that distance is for there, that the ability to see at that distance is. When we move things closer, the lens has to change shape to continue that focal point here. So that's why as people get older, when this lens starts to harden, they can't do that. So they have a hard time. So if they wear glasses, a lot of times they'll have to remove those glasses to see things up close. And I will be honest, that's kind of what I have an issue a little bit with. So if I look at things at 20 feet away with my contacts in, I can see it perfectly. But if you hand me something that I have to read up closer to myself, I'll say like a book or a watch or things like that, I struggle a little bit sometimes, depending on the lighting in the room and the size of the object you've given me. It tends to make that a little bit more difficult for me. But if I were to take my glasses or contacts off, I can see that up close, and it's not a big deal then. This just real quickly is showing us some of the structures in the eye that we will get to see during dissection next week. So you can see this is the overall picture of the eye. Here's the cornea right here. This is the sclera. All right, this has actually now been dissected. So this is the iris. All right, here's your pupil. This is the back portion of the eye. So this is it's laid inside of here. So this is the iris laid inside the pupil with the cornea in front of it. All right, and then you can actually see kind of the edges of that. This is the very back portion of the eye. Since this is a sheep's eye, we're actually seeing that tapetum. All right, so that reflective area on the back. Here's the outside of the back portion of the eye. So again, here is the optic nerve. This is just the white portion, the sclera again. They're now showing us this is the vitreous humor kind of sitting here, and then this is the lens actually sitting on top of that. Okay, and then over here they've cleaned that up a little bit, so now you can see the cornea from the back side, and then the colored area around the outside of it. And then this is just the vitreous humor inside of the eyeball. And then you can see the black portion, which is the retina. The retina is this black area here for the eye. Images formed on the retina are upside down. The brain is what actually turns them right side up, which is why sometimes people can have some issues with, say, like vertigo. So they're looking at it. The brain flips that image, or the eye flips that image similar to the way a camera does, and then the brain flips it upright. Well, if there's an issue between the brain and the eye, then that image stays upside down and people see that image. But that's kind of what we see in there. There's a couple of conditions we can have with sight. You can have what's referred to as myopia, which is nearsightedness. All right, I would make sure you kind of write a little bit of this down specifically because I know that these show up on the assessment. So myopia is nearsightedness. People can see things near. This is emtremia, which is perfect vision. All right, so you can see they can see both far and clear. Hyperopia then is farsightedness, so people can't see things up close but can see things near, or can see things far away, and this is just the other image of that. Here's a little bit more of kind of why that happens. So people with myopia and hyperopia, it has to do with the focal point of the light as it comes into the eye. So perfect vision, that focal point is right there on the back of the retina at that fovea. With myopia, the focal point is in front of the retina. So that's why the image further away tends to be more blurred, and the closer up, it tends to be more in focus. And with hyperopia, that image is being focused behind essentially the eye. So the light rays would actually converge back behind the eye. So the further you get things away from you, the better you can see them as up close. Okay. Corrective lenses then obviously just change the idea of that. So most lenses, if you look at them, are concave lenses because they're helping to kind of focus that light at the right point of the back of the eye. There are odd cases where people need a concave lens, but that usually has more to do with things of like an astigmatism or some other issues inside of the eye. Most lenses, if you look at them, are mostly convex. Okay, this is actually a surgery of what's called the LASIK procedure. So they actually go in and remove this little flap over the top of the cornea, and then with a laser, they use the laser to reshape that cornea, which allows people to then be able to see without the use of external lenses. I'll post these two videos so you guys can kind of take a look at them. If you're squeamish about eye stuff, then obviously don't take a look at them, but they're kind of fascinating. Astigmatism is another issue that we tend to see. So what happens here is instead of the lens being oddly shaped, the cornea is actually oddly shaped. So normal cornea should be pretty well symmetrically round, and in astigmatism, the cornea is actually oblong shaped. So they pretty much have a kind of a fuzzy vision almost all the time. Up close, far away, it doesn't really make any difference. We can change that with a set of corrective lenses that are actually weighted. They call them toric lenses. The lens is actually heavier or thicker on portions of the lens to kind of create the right image that we need there. Okay. Another issue that we can have in the eye is what's referred to as night blindness. This happens in people that have had a prolonged deficiency of vitamin A. And that leads to essentially deterioration of the retina and the back, and they lose their night vision first. This showed up a lot in some of our like very older wars, like World War I, World War II, and before that, especially for captives. They were starved so much or not provided the right amount of food, and they lost a little bit of their vision because of that. Okay. Other issues that we can have are cataract. I think I talked a little bit about that earlier. So this is actually a buildup or a hardening of that lens in the eye. And they end up kind of with this cloudy look in the eye. So the light actually can't pass through that, and most people who have a cataract will see around the edges of their focus, but can't see things in the central portion of their focus. All right, this just shows you a little bit of kind of how that procedure is done. They actually go in through the cornea, they completely remove the lens, and they put in an artificial lens to kind of take its place. This just shows you some of the visual pathways for the photoreceptors and the optic nerves. All right, so from the eyes, the optic nerves actually cross over to other hemispheres of the brain, which is why your vision is some of the best ones we can see, which is interesting. And I'll try to find them. There are a couple of videos specifically that show these kind of visual effects that happen to the eye, but our brain actually removes a lot of things out of our field of view that we probably can see. So the interesting thing is if you look at something in front of you, your nose is in your field of view. Your brain actually removes it for you, all right, because it decides that you don't really need to see your nose, all right, but you need to see what's in front of you. And that's because the images or the information coming from both eyes crosses to both sides of the brain, and the brain essentially can remove that for us. Okay, just shows a little bit more. Then that ends up in both the thalamus as well as the occipital lobe in the back, where most of our vision is. Which is also kind of interesting that, especially in concussions, a lot of times people end up with vision issues because if they hit the back of their head, or even if they have what we call a counter coup injury, where the brain sloshes forward and then sloshes back. They a lot of times end up with some vision abnormalities because of that concussion, or kind of because of the brain trauma. Other things we see is there are some reflexes in the eye. So there are internal muscles that actually that are controlled by the autonomic nervous system. So kind of that autopilot. If you're exposed to bright light, the pupils should constrict. And that's because of the action of those ciliary muscles around the eye. And if you're viewing objects up close, you should be able to actually see people accommodate. So their pupil will actually change shape. And if you're paying close enough attention, you'll actually see the lens itself change shape inside of the eye. So if you wanted to try that, obviously you could just kind of walk into the bathroom, cover one eye, all right, and then take your hand off really quickly, and you'll watch the eye open. You'll watch the pupil dilate on you. If you want to do the accommodation, you're probably going to have somebody be your guinea pig for you, but you can have them hold a piece of paper out in front of them. They're going to slowly move that piece of paper closer. And if you watch them as they do that, you'll watch that accommodation take place. The other thing that we have are the external muscles of the eye control some of those reflexes. And we should be able to kind of move side to side, up and down. And then you also should be able to do a little bit of convergence where you move your eyes medially if you bring something in closer to your nose. So if you ask somebody to focus on your finger and move that finger closer to the point of their nose, you should actually watch their eyes move medially. Some people obviously can control that. They can actually cross their eyes on command. My son is kind of weird. He can actually cross them, and then he can uncross one. It's kind of an odd thing. He loves to do it, kind of freaks his mother out. So these are a couple other ones that we're going to post that are mostly for the dissection pieces, and I'll kind of go through those a little bit with you guys. Okay. All right.